हेलो
बोलो एकदम मजा बोलो बॉम्बे 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 एकदम
ऑडियो ऑडियो चालू नाही माझा ऑडिओ
हाँ तो करे अरे क्या रहा होता बोल 3:30 वागे 3:30 वागे आशीर्वाद
Have you started already?
હું હમણાં થરાથી નીકળું છું.
Has the talk started?
એટલે ક્યાં હે? તો ક્યારે આવો બોલ 3:30
Am I able to?
પાછું જુપિટર જવાનું છે.
Patients, it is generally accepted that coronary artery disease is the most common cardiac pathology underlying sudden cardiac death in adults over the age 35 years. In women, the percentage of sudden cardiac death and CA due to coronary artery disease appears to be lower. In cardiac arrest survivor series and a SCD autopsy series, coronary artery disease was found to be present in 45 to 50% of women versus 80 to 90% of men. Beyond coronary artery disease, the causes of sudden cardiac death are heterogeneous and include cardiomyopathies, valvular heart disease, myocarditis, hypertrophic cardiomyopathy, and certain arrhythmic syndromes, which account for the remainder. On an average, in approximately 5% of sudden cardiac deaths or cardiac arrest, a significant cardiac abnormality is not found after clinical evaluation in SCA survivors or at autopsy in SCD patients. This percentage appears to be higher in women, where structurally normal hearts are more commonly encountered. In Asians, the primary ion channelopathies are estimated to be responsible for approximately 10% of sudden cardiac deaths. In young adults and children less than age of 35 years, coronary artery disease accounts for a much smaller proportion of deaths, with hypertrophic cardiomyopathy, coronary artery anomalies, myocarditis, arrhythmogenic right ventricular cardiomyopathy, and primary ion channelopathies, which account for significant proportions of sudden cardiac death in these patients. Left ventricular systolic dysfunction and severity of heart failure symptoms are currently the strongest predictors of SCD risk among patients with prior MI and or ischemic cardiomyopathy. After myocardial infarction, mortality risk increases gradually until the left ventricular ejection fraction declines to 40% and then exponentially increases as LVF decreases further. The sudden cardiac death rates reach 10% over a median follow-up of approximately 2 years among patients with LVF of less than 30. Stratifying SCD risk based solely on LVF and degree of systolic heart failure has two major well-recognized limitations. First, LVF and NYHA class are both strongly associated with other modes of cardiovascular death, and patients with the greatest functional impairment secondary to systolic heart failure and or lowest LVEF are more likely to die from pump failure rather than SCD. Second, the majority of patients who suffer a SCA or sudden cardiac death do not appear to have LV systolic dysfunction and or clinical heart failure preceding death. Several reports suggest that no single test is alone likely to provide adequate risk stratification. The refined ICD risk estimation following infarction non-invasive evaluation study is evaluating the efficacy of an ICD to reduce mortality in post-infarction patients with ejection fraction of 36% to 49% and abnormal T-wave alternance and heart rate turbulence. The ideal combination of parameters as well as time for evaluation need to be determined. The presence of a pre-existing coronary artery disease was associated with 2.8 to 5.3-fold increases in sudden cardiac death risk. The absolute rate of sudden cardiac death appears to be highest in the first 30 days after a myocardial infarction and decreases gradually with time. Although the proportion of patients who die from non-SCD is greater in the first 18 months, the incidence of SCD after MI has declined in parallel with coronary artery disease mortality over time, with rates as low as 1% per year in patients receiving optical medical management and revascularization. However, rates remain high in certain subsets of post-MI patients. The Ncm Risk Sct Calculator is easily accessible on the web and is a mathematical approach to calculate the individual 5-year SCT risk. The 7 continuous or binary risk factors are used to stratify patients into one of the 3 groups based on 5-year risks of SCT. If the calculated risk is 4%, then an ICD is not advised. It is contingent when a calculated risk is between 4 to 6%, and a greater than risk of 6%, the ICD is definitely recommended. The ESC Ncm SCD risk as calculator does not include genetic testing. It also does not include MRI's late gadolinium enhancement. It also provides blanket recommendations for ICD, and it also does not include an apical HC. 2 methods are currently being used to address these subsets of HCM and the risk of HCD in these subsets. A late gadolinium enhancement of 15% or more of LV mass showed a 2-fold increase in sudden cardiac death event risk. However, available data are currently insufficient to consider LGE as an independent risk marker of SCD. When the level of SCD risk remains uncertain, after standard stratification, the presence of extensive LGE supports the benefit of ICD implantation, whereas minimal or only focal late gadolinium enhancement suggests a low risk. What is the role of genetic testing? In patients with an established pathogenic mutation, fared worse than genotype negative HCM patients, prognostic value of disease-causing mutations in HCM for risk stratification remains questionable. On the other hand, the presence of more than one HCM-associated mutation appears to be associated with greater severity and malignant ventricular arrhythmias as well as SCD. Thus, the identification of multiple mutations on genetic testing can potentially be considered for risk stratification. At present, LVF and late gadolinium enhancement on cardiac MR are the variables considered to identify high-risk individuals who have suffered myocarditis. According to the 2015 International Task Force Consensus Statement, Class 1 indications for ICD placement included a history of sustained VT or BF, severe RV dysfunction, and severe LV dysfunction. However, this ITF consensus statement was less clear regarding ICD placement for primary prevention in patients with ARVC. An ARVC risk calculator, which can be found at www.arvcrisk.com, uses age at diagnosis, sex, cardiac syncope less than 6 months prior to diagnosis, number of T-wave inversions, maximum 24-hour PVC count, history of NSVT, and RVEF to provide a predicted risk of sustained ventricular arrhythmias. Compared with the 2015 ITF algorithm, which treats ARVC as a high, low, intermediate risk, this calculator treats VA risk as a continuum. This new algorithm provides similar levels of benefit and protection from ICD placement at a much lower rate of ICD placement. Then the role of genetic testing as a risk predictor needs further validation. 80% of patients of ARVC have a single copy mutation of plakophilin gene, but the less common mutation of desmoplakin gene is associated with significantly higher rates of SCD. Current guidelines reflect the underestimated relation between arrhythmias and valvular heart disease. Both atrial and ventricular arrhythmias are poorly represented in the AHA, ACC, and ESC, EACTS guidelines on the management of valvular heart disease patients. It is crucial to review the available evidence to clarify management and plan appropriate trials for each type of valvular heart disease by identifying the gaps in knowledge about prevalence, prognostic considerations, and therapeutic options for ventricular arrhythmias in valvular heart disease patients. Due to time constraints, I have limited my discussion to mitral and aortic valves only. The role of MVP in SCD is controversial, but certain characteristics are used to describe an arrhythmogenic mitral valve prolapse. Severe myxomatous disease like marked retentancy and mitral annular disjunction on the morphological side, independent of the degree of MR in the functional side, and with frequent T-wave inversions in the inferior leads and frequent PVCs on ECGs. Typically, patients with bileaflet mitral valve prolapse display more non-sustained VTs and a higher PVC burden on Holter monitoring than those with normal mitral valve. Fibrosis localized to the posteromedial papillary muscle and inferobasal LV wall identified using contrast-enhanced cardiac MR has been shown in pathological studies as a potential myocardial source of ventricular arrhythmias that complicates MV. Patients with aortic stenosis are at highest risk of SCD after valve replacement, particularly within 2 years. Prior to valve replacement, asymptomatic patients with severe aortic stenosis have annual SCD rates of around 1 to 3%, and recent observational data suggests that this risk may be lowered by early surgery. Mechanisms of SCD in aortic stenosis remain undefined between ventricular arrhythmias, AV block, or acute heart failure. ESC guidelines for management of patients with ventricular arrhythmias and prevention of SCD recommend EPS with standby catheter ablation in patients who develop VT following valvular surgery to identify and perform catheter ablation in case of bundle branch re-entry VT. It's a class 2A recommendation. ICD in these patients is recommended based on the following general principles. Autopsy negative SCDs are more commonly reported in younger individuals. Among patients with autopsy negative SCD, approximately 50% have arrhythmic syndromes such as long QT, Brugada syndrome, CPVT, and early repolarization syndromes. Even when structural abnormalities of uncertain significance are found, arrhythmic syndromes appear to underlie a significant fraction of SCDs in these young patients. When a detailed histologic examination is performed, the percentage of autopsy negative SCD is lowered. Histologic examination identifies concealed pathologic substrates like focal myocarditis, regional ARVC, and certain conduction system abnormalities. In cases of sudden unexplained death where a diagnosis is not made either by ante-mortem or post-mortem analysis, a genetic testing of family members reveals a possible disease-causing mutation in 31% of the families. Coronary artery disease underlies as a significant cause for SCD. Hence, all the risk factors for coronary artery disease are associated with sudden cardiac death. The importance of family history of sudden cardiac death. 3 separate case control studies have demonstrated that a history of SCD among a first-degree relative is an independent risk factor for BF or SCD in the setting of an acute MI. Available data in aggregate suggests that genetic or unknown environmental factors may be responsible. Importance of diet, or rather association of diet and SCD. Studies have shown that there are likely additive and interactive effects of certain nutrients on the incidence of SCD. The relationship between alcohol intake and SCD is complex, and a U-shaped association between recent alcohol intake and SCD with reduced risks at levels of half to 1 drink per day and no reduction at 2 or more drinks per day has been demonstrated. Heavy levels of alcohol consumption greater than 6 per day have also been associated with increased risk for SCD in some populations. In contrast, alcohol intake has an inverse linear association with non-fatal MI. Atrial fibrillation, obstructive sleep apnea, chronic kidney disease, and seizure disorder. Although clear mechanisms for SCA, SCD in these patients have not been explained, there is an increased risk in these individuals when compared to the normal population. Adrenergic triggers may underlie in the pathophysiology of all of the factors mentioned above. The incidence of sudden cardiac death tends to be high in the morning periods from 6 a.m. to noon and on Mondays as compared to the overall incidence during weekends. Several studies have examined the impact of short-term air pollution exposures, most often fine particulate matters, carbon monoxide, or oxides of nitrogen, and risk of out-of-hospital cardiac arrests. Most studies, but not all, have found protective associations between regular physical activity and SCD or SCA, particularly for moderate levels of exertion, moderate and habitual levels of exertion. It is also well recognized that SCD occurs with a higher than average frequency during or shortly after vigorous exertion. Depression, anxiety, and psychological stress have all been linked to SCD. A lethal arrhythmia is presumed to be the mechanism underlying sudden cardiac death. A sudden collapse and death in these conditions is because of electrical instability, which leads to mechanical instability and results in an acute hemodynamic collapse. This hypothesis is difficult to prove as most deaths are not monitored. Since PF degenerates to asystole over the course of several minutes, the majority of sudden cardiac death victims demonstrate asystole or pulseless electrical activity when first examined by rescue teams. In cases of sudden cardiac death happening in hospitals, the documented rhythm has been ventricular tachyarrhythmias in majority of the cases. However, as mentioned previously, ventricular fibrillation is less often and VEA is more commonly encountered in the recent out-of-hospital cardiac arrest series. The evaluation of a patient surviving a SCA or a family member of such a patient comprises of multiple steps, each having its own importance and contribution in the understanding of the complex mechanism which causes SCA or sudden cardiac death. Unfortunately, SCD can be the very first presentation of the patient. There may be a prodrome of symptoms like chest pain, dyspnea on exertion, syncope, heart failure, palpitations. A patient with a strong family history of sudden cardiac death may present to the OPD for evaluation and guidance. Clinical history can be used as a tool for a risk estimation. It gives a high pretest probability. The role of history has its importance in cardiovascular atherosclerotic disease, and an indirect attribution to SCD and history can be made. This is because majority of the underlying cause of SCD is coronary artery disease. Whether this is applicable to the general population needs to be evaluated. Physical examination forms a vital part of any evaluation of a patient. No specific markers which tell us the individual risk for SCD, but few examples like an obese individual gives us a clue that he may have obstructive sleep apnea. Irregular pulse tells about atrial fibrillation. Auscultation may tell us about a valvular pathology or HCM. This CCG is an example of a long QT syndrome with a pseudo 2:1 AV conduction. The P waves are marked in red, and the lower red marks are the Ps which are not conducted, giving the appearance of a 2:1 AV conduction block. In this ECG, it is seen that there is a PVC which initiates a non-sustained ventricular tachycardia. This PVC is the target for ablation, catheter ablation, if medical therapy fails. A part of Holter examination showing spontaneous initiation of a wide complex tachycardia. Although we have a wealth of data relating to specific risk factors for sudden cardiac death, there is no widely accepted risk calculator for individual risk estimation for sudden cardiac death. At present, it's practically difficult to implement a cost-effective screening test which is non-invasive because of the low event rate and the large population. There are several studies which have systematically collected such data. These studies can be used as an inception point to establish baseline risk models to estimate risk of SCD. Retrospective identification of data on SCD can pose accuracy problems, especially death certification data. Then prospective study like the Oregon Sudden Unexpected Death Study address some of the limitations of retrospective studies, but then it has its own set of limitations. SCD is a rare event, and even after 10 years, there may not be sufficient data available for analysis. SCD has a multifactorial etiology. This could pose another challenge to and single test to address all these factors. Cardiac MR and genetic evaluation are new approaches which are currently being used for risk estimation or risk stratification of SCD and have shown promising. There are limitations of current approach to sudden cardiac death risk stratification. The current strategy of sudden cardiac death prevention focuses only on patients with known heart disease and does not take into account the dynamic nature of sudden cardiac death as well as the competing risk of non-sudden cardiac death. Finally, implantable cardioverter or defibrillator therapy is associated with a significant complication rate. From the available data, it has been shown that SCD is actually preceded by symptoms in approximately half of the subjects. The presence of symptoms before SCD is an opportunity for a new type of prevention, which can be called near-term prevention. However, a key concern that this strategy raises immediately is the issue of specificity of such symptoms. Whilst the efforts for better acute risk stratification using certain clinical parameters have only been tested in ST elevation MI, the extension to the use of this risk stratification tool to the general population with symptoms still needs to be evaluated in further studies. Beyond clinical variables and or baseline ECG features known to be associated with a higher risk of SCD, the identification of electrical instability occurring in the hours or days before SCD through dynamic monitoring is an exciting possibility. Real-time risk stratification using warning symptoms and dynamic monitoring is a promising complementary strategy, which would be applied not only to high-risk subjects with known heart disease, but potentially to the overall population. Integrating signal monitoring through connected devices into the clinical risk profile and using newer tools such as artificial intelligence will refine identification of patients at risk, improve SCD prevention, and rapidly rescue. SCD remains a high priority public health problem. Beyond prevention of coronary artery disease and heart failure, long-term SCD prevention has not met expectations. ICD or implantable defibrillator has its own clinical implications and is not risk-free. Long-term monitoring and use of artificial intelligence is promising but not without opposition. Bystander CPR training remains an essential tool to prevent SCD.
Okay. Now, unfortunately, Samir could not attend, so I had to transmit his.
Sandeep, the sound was a bit peculiar. What was the reason? The sound was peculiar. It was not normal sound.
Who read it? Sandeep, you read it?
Sandeep, you are muted.
Video band.
Mute. Okay, yeah. My nephew Samir, who is an electrophysiologist, yeah, he prepared the talk, and it was his present. Samir, are you there now? Samir? Samir? No, I think he's not able to. Yeah, but I think that was quite a comprehensive talk on sudden cardiac death. And maybe next time when he's around, we can take up any more questions. Bhaskar, you have anything to add?
No.
Is Bhaskar there?
Yeah, I am there.
Yeah, Bhaskar, anything to add you would like to add? Bhaskar is like Bhishma Pitama. After everyone talks, the final talk has to be by Bhaskar.
We have been doing a lot of MRI and genetic study now at Jupiter in all these patients. And MRI, we find a very important tool to find out which patient is at high risk. May it be ischemic heart, may it be valvular heart disease, or myocarditis, one of those channelopathies. Everywhere we find that getting an MRI done, and if you find there's a scar tissue is more than 15%, probably becomes very important marker for prediction of future sudden cardiac death.
Mhm.
We were not doing it routinely, but now we have been doing left-hearted format. We've also been doing genetic studies for them. These are the only two things which I thought are important.
Yet I think MRI is coming in a big way to identify people with risk, high risk, and maybe something more can be done for such patients.
Hello,
Yeah.
Sandeep, I wanted to ask, like now we are doing too many health checkups, right, for all insurance or routine purposes.
Yeah.
So there, I don't think anyone is paying much attention to identifying risk and subjecting such people to further tests. At least we do just an ECG.
In fact, Bhaskar had reviewed some time back that such routine health checkups are a class 3 indication. They create more problems and more complications from the investigation that we do on a routine basis when you don't have. These are being promoted by hospitals and various diagnostic centers.
Sandeep,
Oh, I
health
agree.
checkups
Then
are
I'm
a cash
saying that-
cow to most of the hospitals. The cash cow.
They are promoted by all these hospitals. Actually, the concepts are really now changing with this corporate hospitals coming up in a big way.
Yeah, exactly. So
Every Wednesday clinical meeting happens.
Acha, that means you're asking
It's not going there.
that tendon reflexes and all that you're asking.
What happened, Raj? You're asking some
no, I
question?
was saying that what I heard was that in hospital deaths are more because of VFib, and out of the hospital deaths are more because of asystole or pulseless electrical activity, right? From that talk of what Dr. Samir was saying.
Yeah.
So how are we to identify those? I'm asking that.
Raj, can you repeat your question again?
I said what I heard from was that most of these in-hospital deaths are because of VFib, right?
Right.
And most of the sudden cardiac deaths out of the hospital are pulseless electrical activities or
Right.
asystoles. Right. So I'm asking, how are we able to identify patients at risk of those whatever? Even if you take a
First thing
complete
is-
history.
Yeah. See, the first thing is that by the time you see a patient who has a cardiac arrest outside, whether it is pulseless activity or whether it started with VTAC, VFib, and then degenerating into a pulseless activity, is a function of time. Because most of the patients who are seen outside, they appear late, they present late to the doctor or to the institute or whatever it is. And therefore, they are being labeled as pulseless activity. Maybe the initiating process would have been still VFib. Therefore, the ideal patients to be studied are in-house, where everything is available and where ventricular fibrillation probably is the key cause. So I think